Welcome to the Deep Dive. Today we're tackling a really big topic for nursing students. Pediatric respiratory dysfunction.
Yeah, it's huge. It's actually the most common reason kids get acutely ill.
Exactly. So building a strong foundation here is, well, essential. We're going to dive into everything from how kids' respiratory systems are different to common things like colds and even more complex stuff like CF and asthma.
hmm
Our mission today is really to pull out the key things you need to know for assessment, understanding these illnesses, and, importantly, the nursing care involved.
Sounds good. And it's fascinating how vulnerable infants and young children are just based on their anatomy and physiology.
Right. Let's start there. Why are kids more susceptible? Our notes highlight some key differences. What jumps out at you?
Well, first off, size. Their airways are significantly smaller.
Okay,
So even a tiny bit of swelling or mucus, it can really narrow that passage dramatically, much more than in an adult.
that makes sense.
And then there are the eustachian tubes connecting the middle ear to the throat. In kids, they're shorter and more horizontal.
So it's easier for infections to travel up.
Precisely.
Right.
Easier for those bugs from a runny nose or sore throat to get right into the middle ear. That's why ear infections are so common.
Okay, and their immune systems are still developing too, right? They haven't built up immunity like we have.
Exactly. Still building that immune memory. Plus, infants are primarily nose breathers for the first few weeks.
Oh, interesting.
Yeah, so even a little nasal congestion can make breathing and feeding actually quite difficult. And don't forget, their lungs have less alveolar surface area overall.
Meaning less space for that crucial oxygen and CO2 exchange.
Correct. Less efficient gas exchange, potentially.
Wow, okay. All those factors really underscore why careful assessment is so vital. We need to catch those warning signs early. So what are the key signs of respiratory distress we should be looking for?
Well, tachypnea is a big one, breathing faster than normal. It's the body trying to compensate, you know?
Right.
You might also see nasal flaring nostrils widening with each breath. They're literally trying to pull in more air. Grunting is another sign, especially in infants. It's like they're trying to keep those tiny air sacs, the alveoli, open.
And what about retractions? I know there are different types.
Yeah, good point. Substernal retractions are when the skin pulls in below the breastbone, intercostal is between the ribs, and suprasternal is above the collarbones.
And they all indicate increased work of breathing.
Absolutely. The child is using extra muscles just to get air in. In babies, you might also see head bobbing for the same reason.
Got it.
Then there's cyanosis, that bluish color around the lips or nail beds. That's a late sign, a serious one, indicating low oxygen.
Definitely a red flag.
And you have to listen closely. Stridor, that high-pitched sound, usually on inspiration, points towards an upper airway issue.
Like croup.
Often, yes. Wheezing, that musical sound, typically means narrowing lower down, like an asthma or bronchiolitis. And sometimes it's what you don't hear. Diminished or absent breath sounds can be just as concerning.
So we're taking in all these clinical signs. What about diagnostic tools to help confirm things?
Pulse oximetry is key. Non-invasive, gives you that oxygen saturation percentage.
Standard practice.
Yep. A chest x-ray can show structural problems or infiltrates, like you'd see in pneumonia.
Okay.
Arterial blood gases, ABGs, give much more detail on oxygen, carbon dioxide, and pH levels, really tells you about ventilation.
Right.
Nasopharyngeal swabs are crucial for identifying viruses like RSV using PCR tests.
Very common, especially in winter.
In cultures, sputum, blood, throat swabs help pinpoint bacterial culprits if we suspect them.
Okay, great overview of assessment. Let's shift to specific conditions. Maybe start with the super common stuff. Nasopharyngitis, the common cold.
Right, the bane of every parent's existence, usually caused by viruses, rhinovirus, RSV, adenovirus, loads of others.
And the symptoms are pretty classic, yeah. Runny nose, sneezing.
Yep, sore throat, maybe a low fever, just generally feeling unwell.
And nursing care is mostly supportive.
Exactly. Focus on hydration, using saline drops to loosen mucus, and gentle suctioning, especially for babies who can't blow their noses. Comfort measures, really.
Okay. Now, what about strep throat, acute streptococcal pharyngitis? That's different, isn't it?
Definitely different.
Yeah.
Caused by a bacterium, group A beta hemolytic strep. And it's important because of potential complications if not treated.
Right, like rheumatic fever.
Rheumatic fever and glomerulonephritis, which affects the kidneys. That's why proper diagnosis and treatment are crucial.
So what are the distinguishing signs for strep?
Often a very sudden onset, really sore throat, fever, headache, sometimes stomach ache. And when you look, the pharynx is often bright red, maybe with white patches, exudate.
And the treatment is antibiotics.
Yes, usually penicillin or moxilin for a full 10 days.
10 days. That's key.
Absolutely crucial. You have to tell parents, finish the entire course, even if the child feels better sooner. It's the only way to fully kill the bacteria and prevent those serious complications.
Got it. Okay, what about tonsillitis?
Well, tonsillitis, the inflammation can be viral or bacterial, so management depends on the cause.
Supportive care if viral, antibiotics if bacterial.
Exactly. And sometimes if kids get it over and over, or if the tonsils are so big they cause sleep apnea.
Then surgery might be needed. A tonsillectomy.
Right. Removing the tonsils can solve those issues.
Okay, and sticking with the upper tract. Ear infections, otitis media, so common in little ones.
Incredibly common. And again, it links back to that anatomy, those shorter, more horizontal eustachian tubes we mentioned.
Makes it easy for stuff to get trapped in the middle ear.
Yep. Signs are usually ear pain. Babies might pull at their ear fever, irritability.
And treatment is typically amoxicillin again.
Usually the first line, yes. And for kids with recurrent infections, sometimes surgeons place tympanostomy tubes, ear tubes, to help drain the middle ear and prevent fluid buildup.
Right, I've heard of those.
All right.
Okay, let's move down to the croup syndromes. The notes categorize them by location above or below the vocal cords.
Correct. Supraglottic swelling is mainly epiglottitis, which is an emergency. Subglottic swelling is what we usually think of as croup or LTB, acute laryngotracheobronchitis.
Let's tackle LTB first, usually viral, common in toddlers.
Yes, very typical. The hallmarks are that distinctive barky cough, like a seal.
Unmistakable sound.
It really is. Plus, inspiratory stridor, that noisy breathing on the way in and retractions, showing that effort.
And how do we manage LTB? I see cool mist, nebulized epinephrine, corticosteroids listed.
Right. Cool mist can soothe the airway. Nebulized epinephrine is really important. It's a vasoconstrictor.
So it shrinks the swelling.
Exactly. Narrows the blood vessels in the airway lining, reduces swelling quickly, opens things up. Corticosteroids work on the inflammation itself, giving a longer-lasting effect.
Okay, that makes sense. Now, epiglottitis. You said that's an emergency.
A true medical emergency. Usually bacterial, often Haemophilus influenza type B, though the Hib vaccine has made it much rarer, thankfully.
Still need to know about it, though. What are the critical signs?
It comes on fast. Severe sore throat, difficulty swallowing, dysphagia, so they often drool because swallowing hurts too much, and their voice might sound muffled.
And the big warning.
Do not attempt to examine their throat. Don't stick anything back there.
Why not?
It could trigger a complete airway spasm and obstruction. Life-threatening.
Wow. Okay, crucial point. So, immediate priorities.
Airway support first. Intubation might be necessary right away. And IV antibiotics, quickly to fight the infection.
Got it. A very serious situation. Okay, moving further down now. Bronchiolitis, often caused by RSV, right? Especially in infants.
Yes, RSV is the most common culprit, particularly in babies under 2.
And what does bronchiolitis look like?
You'll typically see cough, wheezing, maybe some crackles in the lungs, retractions, and often poor feeding because they're working so hard to breathe.
How's diagnosed?
Usually a nasal swab for RSV confirms it.
And treatment, is it antibiotics?
No, because it's usually viral. Treatment is primarily supportive. Oxygen if needed, making sure they stay hydrated. For high-risk infants, there's a preventative medicine, palivizumab, given monthly during RSV season.
Okay, supportive care. Now, pneumonia can be viral or bacterial.
Correct. Causes vary. Presentation usually involves fever, cough, maybe producing sputum, crackles when you listen, fast breathing, sometimes chest pain.
Diagnostics.
Chest x-ray is key to see those infiltrates, the inflammation or fluid in the lungs. A sputum culture can help identify bacteria if we suspect it.
And treatment follows the cause.
Generally, yes. Antipyretics for fever, definitely fluids. Antibiotics are essential if it's bacterial.
Okay. What about tuberculosis, TB, caused by Mycobacterium tuberculosis? What's important for kids?
Well, identifying risk factors is key. Exposure to someone with active TB, being immunocompromised, travel to areas where TB is common.
And symptoms.
Can be subtle in kids. Persistent cough, maybe weight loss, night sweats.
Diagnosis involves
The TB skin test, the MAN2 test, chest x-ray, and blood tests called IGRAs.
And treatment is long-term medication, right?
Yes, a combination of drugs like isoniazid, rifampin, ethambutol, pyrazinamide, often for 6 months or more. Adherence is really critical.
Definitely. Okay, let's talk about asthma. Very common chronic condition, described as chronic inflammation with hyperresponsiveness. Can you unpack that?
Sure. Basically, the airways are persistently inflamed, sort of swollen and sensitive, and they overreact. That's the hyperresponsiveness to triggers.
What kind of triggers?
Lots of things. Allergens like pollen or dust mites, cold air, exercise, smoke, even viral infections.
And when triggered, what happens? That's an asthma attack or exacerbation.
Right. The airways narrow due to muscle spasm and increased mucus. That causes the classic wheezing, coughing, chest tightness, and difficulty breathing or dyspnea.
How is it diagnosed?
Often based on history and pattern of symptoms, spirometry, lung function tests are really helpful to measure airflow. Peak flow meters can be used at home for monitoring.
And treatment involves different types of meds, rescue and controller.
Exactly. Rescue meds are for quick relief during an attack. Albuterol is the most common, a short-acting beta agonist. It relaxes airway muscles quickly, opens things up.
Bronchodilation.
Yep. Controller meds are taken daily, long-term to manage the underlying inflammation and prevent attacks. Inhaled corticosteroids are the mainstay here.
Like Flovin or Pulmicort.
Right. They reduce that airway inflammation. Leukotriene modifiers are another type, taken orally.
And education is key here too, isn't it?
Hugely important. Teaching kids and parents about triggers, how to use inhalers correctly, and having a clear asthma action plan for managing symptoms.
Makes sense. Now, cystic fibrosis, CF genetic disorder affecting exocrine glands. What does that mean for the lungs?
It's an autosomal recessive condition. A faulty gene causes the body to produce really thick, sticky mucus.
Okay.
In the lungs, this thick mucus clogs airways, traps bacteria, leads to chronic infections, inflammation, and eventually lung damage.
What are other signs?
Chronic cough, frequent pneumonia or bronchitis, poor weight gain despite eating well, and greasy stool statorrhea because mucus also blocks pancreatic ducts, affecting digestion.
Diagnosis. I know the sweat test is important.
Yes, the elevated sweat chloride test is a hallmark. Genetic testing confirms the specific mutation.
And treatment sounds complex, multi-system.
It really is. Airway clearance is vital. Techniques like chest physiotherapy, vests that vibrate. Pancreatic enzymes must be taken with every meal to help digest food.
High-calorie diet too.
Yes, to combat malabsorption. And inhaled meds are crucial. Bronchodilators to open airways, mucolytics like Dornase alpha to thin the mucus, and often inhaled antibiotics to fight infections.
A lot to manage. Okay, what about foreign body aspiration? High risk in toddlers, right?
Yes, that 1 to 3-year-old range. They explore everything with their mouths. If they inhale something small, a peanut, a small toy part,
It's stuck?
it can lodge in the airway. Symptoms are usually sudden: choking, coughing, wheezing, maybe stridor. Sometimes breath sounds are different on one side.
Diagnosis?
Chest x-ray might show it, but not always, especially if it's food. Bronchoscopy is usually needed inserting a camera into the airway.
And that's how it's removed too.
Yes, removal via bronchoscopy is the definitive treatment.
Okay, let's touch on apnea and Altipru. Sounds scary for parents.
Apnea of prematurity is specific to preemies due to their immature respiratory control, usually resolves as they mature.
All right.
ALTE, apparent life-threatening event, is now often called BRUE, brief, resolved, unexplained event. It's when an infant suddenly has apnea, color change, maybe goes limp, but then recovers, and there's no clear cause found immediately.
Very frightening.
Extremely. These events usually need investigation in the hospital to rule out underlying problems.
Right. And finally, smoke inhalation injury, 3 phases.
Yeah, the immediate injury is from heat and chemicals irritating the airway. Then, pulmonary edema fluid in the lungs can develop over the next 6 to 72 hours.
And the 3rd phase.
Bronchial pneumonia, an infection setting in later. Management involves humidified oxygen right away, bronchodilators to open airways, and potentially intubation and ventilation for severe cases.
We've covered so much ground. Bringing it all together, what are the core nursing management principles for any child with respiratory issues?
Priority number 1, always. Airway and breathing assessment. Continuous monitoring. Absolutely. Oxygen therapy is common, tailored to the child's needs: cannula, mask, high flow. Hydration is critical fever, and rapid breathing lead to fluid loss.
Positioning, too.
Yes, elevating the head of the bed often helps ease breathing. Medication administration needs to be safe and accurate: bronchodilators, steroids, antibiotics when indicated.
Involving the parents.
Essential. Parent education is huge. Teaching them about meds, especially inhaler technique, recognizing warning signs that mean they need help, and basic infection prevention. Empowering them is key.
This has been incredibly helpful, a really thorough deep dive. It's so clear how vital that nursing knowledge and assessment are for these kids. Vigilance and quick action makes such a difference.
Absolutely. And it's a field that keeps evolving with new understanding and treatments emerging.
A great reminder for us to keep learning. Thanks so much for breaking all this down today.
My pleasure.
And thank you all for joining us on the deep dive.